Good evening, everyone. Yashoda Group of Hospitals welcomes you all to the Tuesday academic sessions. Today, we have an interesting topic in emergency medicine, the environmental emergencies. The environmental emergencies, they differ from the other emergencies both in presentation and the management as well. The environmental factors are inseparable from the human life and existence. But any exposure to these environmental elements, either in excess or a lack of them, or inappropriate way of exposure to them, these can result in life-threatening emergency conditions. The temperatures, I would like to share my screen. Yeah. The temperatures are skyrocketing year by year and resulting in various conditions ranging from the simple heat cramps to heat stress, heat exhaustion, and very dreadful condition like heat stroke, which affects the central nervous system. On the other extreme, the exposure to cold, extreme cold, that can result in cold injuries, which can range from very simple skin damage leading to blistering, or it can even progress to various conditions like chilblains, frostbite, and in extreme exposures due to intense vasoconstriction, there can be a complete cutoff of the blood supply, resulting in the gangrene of the distal extremities. And are these conditions seen only in the people who go for trekking or mountaineering? No. Even we may encounter these patients. It can happen because of occupational hazards, occupational exposure to the people working in food storage units, cold storage units, and ice block factories. Or it can even happen, the hypothermia we can even encounter in alcoholics who are left there in the open throughout the night, and their reflexes are blunted because of the effect of alcohol. They can land up in hypothermia. So we may encounter such conditions. Then come the adventure sports, the people who go for mountaineering, trekking at high altitudes, and particularly at the high altitudes, these persons can land up in conditions like high altitude pulmonary edema or high altitude cerebral edema, which are very dreaded conditions. Due to diving, we may face very serious conditions like air gas embolism, which occurs due to either rapid ascent or rapid descent into the water. And in patients who undergo drowning, there can be a damage to the lungs, heart, and brain. In the nature, there can be various there can be sustained various bites and stings due to various insects, the spiders. And India being a rural country, having a major population in the rural areas, the people are exposed to various snake bites. And in the coastal regions, there is always a chance for marine trauma and envenomation. Burns can happen due to various thermal and chemical reasons. And in the open areas, there can be electrical injuries and lightning injuries. Particularly in these kinds of injuries, we need to pay attention to the cardiac status. The cardiac status and thorough cardiac monitoring is needed in these patients. The exposure to various poisonous plants can result in different conditions, starting from the very mild allergic reactions to life-threatening anaphylactic reactions. Mushrooms are being consumed by a lot of population in our country, but the consumption of poisonous mushrooms can result in a serious situation. The carbon monoxide, the gases, particularly the carbon monoxide, which is a part of the byproduct of combustion of various substances. This can also result in serious levels of poisoning, resulting in loss of consciousness and severe dizziness, the mild symptoms of which may vary from headache to nausea. So there are various environmental factors that can affect us. And today we want to discuss about two patients who presented to our emergency department. Dr. Qamar, our DNB resident, will brief us about these patients and how we have managed them. Over to Dr. Qamar.
Good afternoon, good evening, everyone. I have two cases to share with you. I'm a third year DNB emergency medicine resident at Yashoda Hospitals Hyderabad. Good evening, everyone. I have cases to share with you. I'm a third year Hello. Hello, can you hear me?
Yes, sir, we can hear you.
Okay, I'll continue then. There are two cases which I would like to present in this webinar. This is case number one. 57-year-old male brought to emergency department around 2:30 with a history of nausea and vomiting since yesterday, and fever and generalized weakness since the day morning. And patient was unresponsive at home since last 2 to 3 hours, and there was no history of loose stools, abdominal pain, headache, seizures. So on arrival, we did a primary survey. Airway was threatened but maintainable. The patient did not have any gurgling sounds or pooling of secretions. We did a head-tail chin rest maneuver for this patient, and a nasopharyngeal airway was placed, with after which a high-flow oxygen was started through non-breathable mask. After the airway was secured, the breathing in the breathing part, the patient was very tachypneic with a respiratory rate of 40. Trachea was central, bilateral chest rise was present, and saturation was 100% on high flow O2 that we started in the airway. Because of increased respiratory effort, we continued the oxygen through NRBM. Coming to circulation, distal pulses were very feeble but felt. Pulse rate was 140, blood pressure was not recordable, and capillary refill time was more than 3 seconds. So one initial 500 NS bolus was given, 500 ml, and reassessed later. In disability, GCS on arrival was E1, V1, and M1. Pupils was 3 mm bilateral but briskly reactive to light, and our GRBS was 304. On exposure, we checked the temperature. It was more than 108, and there was no signs of external trauma. So we started sponging here, and we continued that during the ER stay. And later on, we did send some primary adjuncts, which was ECG, which showed sinus rhythm with no STT changes. It was having tachycardia with a heart rate of 138 and a normal interval in segments. ABG was sent, which was suggestive of compensated metabolic acidosis of pH of 7.44, PCO2 was 99.5. Potassium was 6 in the ABG, for which we gave corrections. Lactates was 5.63 and creatinine was 9. So basically, it was a metabolic acidosis with hyperkalemia and with AKI. Screening echo was done, which showed a fair LV function with no RWMA, and IVC was collapsible. At this point, the differential diagnosis that we made was CNS infection, cerebrovascular accident, dyselectrolytemia, septic or metabolic encephalopathy, poisoning, heat stroke, acute kidney injury, and de novo diabetes with DKA. Ample history, the patient had no known allergies. On medication, patient was on ecosprin and claptrap 75 milligram per oral once daily. And he had a past medical history of coronary artery disease, for which he underwent a PCI in January 2019. No history of any alcohol intake or smoke. He was not a smoker also. Last meal was taken 8 in the morning, the same day. Coming back to the event, patient was apparently all right 3 days back when he started complaining of being unwell, and he took a leave from his office job and complained of nausea, and he had 5 to 6 episodes every day of vomitings, which was not relieved by the OP medications that he was prescribed. The day of arrival in ER, the same day in the morning, he complained of some fever, generalized weakness, and wife noticed him unresponsive on his bed 2 hours before the patient was brought to the emergency department. No history of trauma, assault, and no suspicious consumption of any toxic substances. Nothing was lying around the patient. On systemic examination, CNS E1, V1, M1, pupils were bilateral 3 mm equally reacting to light, and there were no signs of meningeal irritation. Bilateral parameters were mute. Cardiovascular, respiratory, and per abdomen systems were normal. On head-to-toe examination, there were no obvious signs of trauma or assault, no signs of bites, no cutaneous markers of systemic diseases, and entire examination was apparently normal. Provisional diagnosis at this point were cerebrovascular accident, a heat stroke, septic or metabolic encephalopathy, acute kidney injury, and de novo diabetes. Investigation, which included metabolic profile, coagulation profile. We sent a CT lung screening as the patient came during the COVID pandemic, and an MRI brain plane was also done. Diabetic profile on HbA1c was sent, and blood and urine cultures were sent. The patient arrived at 2:30. That time we started at apixaban. We gave a paracetamol 1 gram and total 1 liter of NS bolus was given, followed by 125 ml of infusion of NS was continued. Patient was reviewed as at 15 minutes later at 2:45. At this point, the BP was still non-recordable. So we gave another 500 ml of NS bolus. And at this point, we got an ABG which showed a potassium of 6, for which a D25 100 ml with 10 units of ectopet insulin was given IV, and a calcium gluconate 10% 10 ml over 10 minutes were given. Patient was covered with a thin wet sheet of cloth, and pedestal fan was used for evaporative cooling at as the temperature was more than 108. Patient was again reviewed at 3 o'clock. BP was still NR. Respiratory rate came down to 32 from 40. Saturation was still 100% on 5 liters. Initially, we gave high flow O2, but we decreased it to 5 liters. Still, the saturation was good. Pulse rate came down to 130, but the GCS remained the same, E1, V1, M1. Even at this point, the airway was not compromised. It was threatened, but maintainable. We repeated the echo here, screening echo, in which the IVC was still less than 1 centimeter. With mild LV dysfunction, we got earlier also. So we gave another 500 ml of bonus, and we continued at 125 ml per hour. And because the BP was not improving despite 1.5 to 2 liter of NS bolus, we started a dopamine infusion at 5 microgram per kg per minute and titrated to blood pressure. Urine output till this time was nil. BP was 60 systolic at after 15 minutes. Pulse rate was 130. Temperature came down to 102 Fahrenheit. Respiratory rate was 28. It came down from 40. Saturation was still 100% on 5 liters, and GCS improved to E2, V2, M1. We continued IV fluid at 100 ml per hour and continued evaporative cooling, and nephrology consultation was taken in view of AKI and neurology consultation in view of unresponsiveness. Patient reviewed after 15 minutes. The BP improved to 90 systolic on dopamine, and pulse rate came down to 120, temperature at 101, and GCS improved to E3, V2, and M4. 2D echo departmental was done here, which showed fair LV function with IVC collapsible less than 1 centimeter. HRCT chest was done at this point, which was normal. And as the temperature reached 101, we stopped evaporative cooling to prevent overshoot hypothermia. And the patient was reviewed after half an hour, which showed a BP, pulse rate, and saturation and temperature was well maintained, and GCS was still E3, V2, M4. Till now, there was no urine output, after which the patient was reviewed at 4:30. At this point, patient symptomatically, he was still E3, V2, M4, but his urine output started coming. In the last half an hour, the 20 ml of urine output came. We continued fluid at 125 ml per hour. At 5 o'clock, BP improved to 100 by 60, pulse rate came back to normal, respiratory rate came back to normal, saturation he was maintaining 98% on room air, temperature came back to normal, GCS improved to E3, V2, M5. So MRI brain plane was done at this point, and the MRI was normal. Patient was shifted to ICU for further care at this point. After 1 hour, patient was reviewed in the ICU. BP was 100 by 70 on dopamine infusion. Rest vitals were stable. GCS improved to E3, V3, and M5. Lab values also received at this point, which was sent from the ER on arrival, in which electrolytes, potassium was 6, INR was 1.3, CPK was 2.16. Rest were almost the same. At 8 o'clock, patient's GCS improved to E4, V4, M6, and as ABG was repeated, which was quite improved as compared to the arrival ABG. The acidosis has come down, the lactates have come down, the creatinine has come down, and bicarb has also improved in the ABG. Patient reviewed next day in the ICU. Patient was stable, not on any inotrope support. GCS was 15 by 15, and serial ABG showed resolving acidosis. Out of the box, in this, actually the important points to discuss is the aggressive airway management was withheld with close watch on the airway. Rapid body cooling technique were instituted, and choice of inotrope changed in view of hypothermia, as we withheld noradrenaline in such cases. This is the patient on the same day who arrived at a GCS of 3, and he was reviewed at 8 o'clock. After 6 hours of stay in the hospital. This completes my first case. I'll be moving on to the second case. This is a case of second case, the 45-year-old male brought from local ice block factory at 5 o'clock by co-workers with history of found unresponsive in the cold storage room. Patient came on duty at 8 in the morning that day. No history of fall, trauma, assault, or poisoning. Airway on arrival was threatened but maintainable. No oral pooling of secretions or gurgling sounds were there. Nasopharyngeal airway was placed and patient started on high flow O2 by non-rebreathable mask. In breathing, trachea was central, chest rise bilateral were fine, no added sound, saturation was 100% on NRBM, respiratory rate slightly less at 10 per minute. On circulation, distal pulses were very feeble, extremities were ice cold, BP was 50 systolic, pulse rate was 52. So, because the patient BP was less, we gave a fluid, 500 ml bolus fluid challenge was given. GCS on arrival was E2, V2, M4. Pupils were 3 mm bilateral but sluggishly reacting to light. GRBS was 102. On exposure, temperature which was measured by axillary mercury thermometer, which we commonly use, had 94 Fahrenheit in it. It was below that. It could not measure below it. So we removed wet clothes from the body and we dried the body, and warm blankets were placed around the patient. Primary adjunct, we sent an ECG. We did an ECG which showed sinus bradycardia with heart rate of 54. No intervals and segments were normal, and there were no ST changes or abnormal wave patterns. ABG showed mixed acidosis. Screening echo had mild global LV hypokinesia, but IVC was less than 1 centimeter. So differentials at this point was hypothermia, cerebrovascular accident, and unknown poisoning. Ample history, patient did not have any allergies, no daily medication, no past medical or surgical illness, and he took his last meal in the breakfast at 7 in the morning, 7:30. Events, patient came to the work at 8 in the morning, went for regular checking or temperature reading of the ice block factory area. Co-workers didn't see the patient at lunch, which they usually do at 2:30. Patient found unconscious on the floor at 4 p.m., after which he was carried to Yashoda. He was not given any on-site treatment and no hospital visited in between the factory and Yashoda. Systemic examination, CNS had E2, V2, M4 with pupils bilateral to 3 mm, sluggishly reacting to light. Cardiovascular, respiratory, and parabdomen was normal. Head-to-toe examination, patient did not have any external obvious wounds. Upper and lower limbs were stiff. Capillary refill time was more than 6 seconds. Distal pulses were not palpable. Weak carotid pulse was present, and no obvious skin color changes in the extremities. Provisional diagnosis at this point was hypothermia, moderate to severe, cerebral vascular accident, and poisoning. We sent some metabolic profile, a chest X-ray, and 2D echo, including serum osmolarity and toxicology screening. At 10 minutes after arrival, BP after the first initial bolus went up to 60 systolic, after which we gave 1 liter of warm normal saline bolus. Pulse rate was still 54, respiratory rate improved to 12. Saturation, we decreased the oxygen flow to 5 liters, still he was maintaining 98. Temperature measured by esophageal thermometer came 32 Fahrenheit, which brings him to moderate hypothermia category. GCS was E2, V2, M4. At this point, we continued warm normal saline at 100 ml per hour after the initial bolus. We moved the patient to a non-AC area, completely covered him with warm blanket, and we put a 3-way urinary catheter, 18 French, and warm saline irrigation was started with 40 degrees Celsius normal saline, 4 liter per hour. Continuous cardiac and core temperature monitoring was done to see for any dysrhythmias. After 15 minutes, BP improved to 80 by 50. Pulse rate was improved to 68. Saturation was still maintaining on 5 liter 96. Respiratory rate improved to 15 per minute. Temperature was 33 degrees Celsius. It improved from 32. GCS also improved to E2, V2, M5. Screening echo was repeated again here as we gave almost 1.5 liter bolus. Screening echo still IVC was less than 1 centimeters. So we gave another 500 ml of warm bolus and continued 100 ml per hour. And external rewarming was also continued with warm blankets. After 15 minutes, the BP was stabilized at 90 by 60, pulse rate improved to 72, saturation 98 on Hudson mask from NRBM, and respiratory rate was 16. Temperature improved to 35 degrees Celsius and GCS improved to E2, V3, M5. GRBS was 1.25 at this point. Departmental echo was done and it showed fair LV with IVC was totally collapsed and no regional wall motion abnormalities. We continued the IV fluid at 100 ml per hour. Patient was reviewed after half an hour. BP, pulse rate, saturation, respiratory rate were all normal. Temperature went up to 36 degrees Celsius and GCS improved to E3, V4 and M6. And a neurology opinion was taken at this point. After half an hour, the patient BP, pulse rate, respiratory rate was normal. Temperature went up to 37 degrees Celsius and saturation he was maintaining 94 on 2 liters on nasal prox. He was initially on Hudson mask before this. So at this point, we stopped the warm saline infusion and we started room temperature normal saline at 100 ml per hour, and rewarming was stopped, blankets removed and patient placed on comfortable clothing, and general medicine consultation was given for admission. Patient reviewed next day in ICU. Patient vitally was stable, no supports. Systemic examination was normal. Blood reports, other serial blood reports were normal. So in this patient, we prevented an aggressive airway management, although not contraindicated in hypothermia, but we prevented an aggressive airway management, and close frequent monitoring was done for the airway. One important thing we could have used as a bear hugger machine could have been used for a more effective external rewarming, and ECMO is considered in some cases which intractable severe hypothermia which are not warming up quick enough. And other lavages like thoracic, peritoneal, gastric, and rectal are not done now as they have high morbidity. Only urinary bladder lavage is indicated now. Thank you.
These are two really very well managed cases, Dr. Akhtar. And let us proceed, especially when the patients have been exposed to the two extremes of the temperature. Now let us proceed to the management of the other environmental emergencies and how we need to think out of the box when we encounter such cases. This will be done by our emergency room physician, Dr. Saikiran Reddy.
Yeah, good evening, one and all. Today, I'll be dealing mainly with the management of environmental emergencies, which is the most important topic we deal with. This would be my outline dealing today about various environmental emergencies. Any decrease in core temperature below 35 degrees is considered as hypothermia. Accidental hypothermia, which is a pathological one, where involuntary drop is below 35 degrees. The same principle is used in case of post-cardiac arrest status, which is in therapeutically, which is also called as targeted temperature management. Accidental hypothermia is again classified into primary and secondary. Primary would be due to simple environmental exposure, and secondary would be due to impaired thermoregulations. And these are the various stages of hypothermia, that is mild, moderate, and severe. It depends on the core body temperature and the clinical symptomatology. For mild, mild would be between 32 to 35 degrees, moderate would be from 28 to 32 degrees, and severe would be less than 28 degrees. Any temperatures below 32 degrees would have a definitive risk of cardiac arrest. These are the various managements, treatment modalities which we use. For mild hypothermia would be passive rewarming, and a moderate and severe hypothermia would be maintaining the active external rewarming and minimally invasive rewarming. Along with that, we need to take the decisions whether we need to shift the patient to the extracorporeal life support centers or the ECMO centers. There are certain decisions that we need to take when we see regarding the patients with hypothermia, like vital signs are present or not, impaired signs of consciousness, and any pre-hospital cardiac instability. If these are there, then definitely the patient would be coming to various centers that is possible. The main motto would be shifting the patient either to the nearest hospital or to the nearest ECMO center, or initiating the passive rewarming techniques. We should have a clean point in consideration for any chances of ECMO or cardiopulmonary bypass, because patients with such severe hypothermia who are matching for this resuscitation would need an early ECMO or cardiopulmonary bypass within 6 hours of identification. These are the various rewarming techniques that we use. Wrapping him in a waterproof wrap or insulating pad, replacing wet clothes with if practical. If not, then you have to change it with a plastic clothing. External forced air rewarmers or insulating blankets can be used. Insulating the head. The most important point here is whenever the patient is in cardiac arrest, you should not apply the heat to the head, because you should allow the warm blood to circulate in the brain centrally. This is a classical presentation of Osborne J waves in case of hypothermia. J wave is just after the QRS complex and before the starting of ST segment. There is an elevation which is seen in all the leads associated with ST segment depressions. There are certain different rewarming techniques that we use in hypothermia. There are active and passive rewarming techniques and internal core rewarming techniques. Coming the most experimental is truncal diathermy, and the most recent one and extraordinary one would be extracorporeal blood rewarming. Always there is a challenge for an emergency physician when you come for declaration of the death. It differs in children in case of hypothermia where it needs an expertise. Coming to recommendations regarding the defibrillation, usage of epinephrines or time intervals, European Resuscitation Council says 3 doses of defibrillation. Later, you should withhold up to 30 degrees centigrade. And withhold epinephrine up to 30 degrees centigrade and double the interval of time at which you administer regularly as 3 to 5 minutes. But here we need to use it 6 to 10 minutes up to 35 degrees. And later it's normal. Coming to American Heart Association, in the absence of clinical response, after the 3 cycles of ACLS, defer the further defibrillation. Always your target before declaration or before termination of your resuscitation efforts, you need to target the temperature of 32. There are certain special considerations which we take in case of hypothermia. Any centers with ECLS, that means extracorporeal life supports and extracorporeal membrane oxygenation, definitely there is a good amount of survival rate. Any patient in drowning should be maintained at a horizontal position while extricating him. And avalanches, definitely there is a point that you need to remember. Any extrication time less than 35 minutes can be considered for resuscitation. Any time above 35 minutes with irreversible signs of death and associated with any external trauma, definitely the resuscitation would be futile. Austere environments, these are the extreme environments where transporting of the patient with resuscitative efforts or without resuscitation efforts is a very big question, because there are some patients who are not resuscitated during the transport but still have a very good outcome. Next, we'll be dealing with heat stroke. These are extreme forms of hypothermia where the core body temperature is above 40 degrees associated centigrade associated with altered mental status. There are no diagnostic tests for the heat stroke. It's a diagnosis of exclusion. You have to differentiate whether it is an exertional or a classical. Exertional, the word itself says, whenever a young individual, healthy individual exercises for a long period of time with sporadic and presents with diaphoresis and hypoglycemia, when evaluated in mild forms can be of mild to moderate forms can be of acute renal failure, marked lactic acidosis, and hypocalcemia. In severe forms, it can also present with diffuse intravascular coagulation or rhabdomyolysis. If you see a classical hypothermia, predisposing patients with sedentary lifestyle, older individuals, predisposing factors with medications, presents to you in anhidrosis, normoglycemia. When they are evaluated, there will be findings of elevated acidosis and elevated CK levels with mild coagulopathy and normal levels of calcium. These are the various cooling techniques in hypothermia, where you have to your target of getting the temperatures of the body to the normal. There are invasive techniques and non-invasive techniques. If you see non-invasive techniques, evaporative cooling method is the very best and effective cooling method which is available, and associated with application of ice packs to the neck, axilla, and groin. But the main point here is immersion cooling will have a poor tolerability to the patients, which is recommended, which provides the effective cooling method, but it can cause shivering. Okay, and invasive techniques, if you see irrigation of the bowel bladder, irrigation of the gastric, urinary bladder, rectal or peritoneal lavages, and application of the cardiopulmonary bypass, which is the most fast and effective way of cooling method. If you see the complications of heat stroke, if left untreated, it can not only present with the alteration of the vital signs, can also affect all the organs. In early complications of heat stroke, patient presenting early to you can present with rhabdomyolysis. Neurologically, he can present electrolytes. And in late complications of heat stroke, if not treated, can go with severe form of diffuse disseminated intravascular coagulation and dysalkylatemia. What you have to think out of the box here. Normally, whenever a patient with high temperatures come to you, you start treating them with antipyretics, which are seen to be very ineffective in this scenario. And this mimics the viral illness, and this resembles the pulmonary edema. But in spite, it requires a very high crystalloid resuscitation, and rapid cooling has to be initiated as early as possible before establishing a differential diagnosis. More vulnerable people are extremes of age. Prevention is always better than cure. And coming to other environmental emergencies, bites and stings, it can present from a mild form of urticaria to a severe form of anaphylaxis. And you should be watchful about the delayed unusual reactions. And the mainstay of treatment for mild cases would be antacids, antihistaminics, steroids, and hydration. Going to marine envenomations, there are a large number of animals which we encounter here. We have to identify, remove the further exposure from the teeth, spine, or any foreign bodies. Give a good care to the wound, initiate on steroids, and if antivenom is available, definitely that is a definitive treatment of choice. Coming to snake bites, there are a wide range of snakes all over the world, predominantly in Asia, WHO protocol. We think of big fours where we have a local and hematological and neurological manifestations where they present with. The polyvalent ASV is the drug of choice that we have to initiate. The main important point here in snake bites is remembering that the dose for children and the adult remain the same. This is the most important thing. Hygiene disorders, there are problems, there is barotrauma due to descent, due to ascent. Due to ascent, the ear and the sinuses are the main areas where we have to concentrate and which creates the problems. And due to ascent, the respiratory and
Dr. Saikiran. Dr. Raghavendra.
hello.
Yes, sir. Can you please continue?
Is it audible? My slides are
Dr. Sai, now we are able to hear you. Please continue.
Please share your presentation, sir.
Can I continue?
Yes, sir.
Yes, we are able to see you and hear you. Please continue, Sai.
Yeah, please. The main thing in drowning we have to see is whether any on-scene CPR or CPR and the ED have a guarded and poor prognosis. Coming to high altitude illnesses, there is a mild form of acute mountain sickness to the severe form of cerebral or pulmonary edema. The main thing here is you have to stop the ascent and ask the patient to descend if the symptoms do not abate. Main thing is rate of descent here, and main thing you have to do is come down as early as possible and get the treatment as soon as possible. Coming to burns, You have to calculate the percentage of burns, see the degree of burns, and assess the percentage. Appropriately, the fluid has to be initiated according to Parkland's formula, and analgesia has to be monitored because we have to give the care for the pain. Along with that, wound dressings in the local applicants. If there is any burns to the chest wall or in the neck, escharotomy surgically has a very high need in extreme and severe cases. In case of chemical burns, apart from the local manifestations, we have to keep a watch on systemic manifestations, where the site of the body which is involved and the type of the chemical and the duration of exposure is the most important. The mainstay of treatment would be irrigation and decontamination. And external and lightning injuries, any voltages below 600 volts is considered as low voltage, and any voltage above 1000 is considered as high voltage. The main treatment or monitoring required is cardiac monitoring for dysarrhythmias. Along with that, the fluid resuscitation and the cutaneous burns have to be treated. Mainly, there is a difference between lightning and electrical injuries. Lightning are very high voltage electrical lightning injuries from 10 million to 2 billion. The aggressive efforts will have a better outcome. And this is one of the scenario where we have to prolong the CPR. Mushroom poisoning can manifest from a mild gastroenteritis to a severe central nervous system disorders. And along with that, it can produce a delayed disulfiram reaction when consumed with alcohol. And it can also cause liver failure. The mainstay of treatment should be antacids, antiemetics, IV fluids, antihistaminics, and inotropic supports, and N-acetylcysteine for the liver protection. Coming to the last topic of carbon monoxide, the main points to remember here is shift to left of oxygen dissociation curve, and the levels in the smokers and non-smokers definitely differs. The levels of carbon monoxide. The mainstay of treatment for mild cases would be observation, high oxygen therapy, and the first extreme forms would be hyperbaric oxygen therapy. Thank you.
That's an extensive yet lucid presentation about the management of various environmental emergencies. And I see here that there are quite interesting questions over there in the chat box. We proceed to them. So, what is the importance of J waves seen in ECG in hypothermia cases? I think Dr. Sai, you have just now told about the J waves. Can you just tell us about this?
Yes, sir.
In what way they are important?
If you see the J waves just after the QRS complex and starting of the ST segment, there will be an elevation of a J point, which is predominant in temperatures less than 32 degrees. And it can be misinterpreted for ST segment elevation, myocardial infarctions, hypercalcemia, and in case of early repolarizations.
Okay, so there's always a chance to think it as a ST elevation MI, looking at the J waves, right?
Yes, yes, sir.
Okay.
Definitely.
There's another question. Why is dobutamine chosen in heat stroke case management despite the hypotension? I think I will take this question. Yes, dobutamine has been chosen in this case. And as we know, the only two inotropes that we need to use in case of hypotension in management of a heat stroke case are only dopamine and dobutamine. Noradrenaline is completely contraindicated because of the intense vasoconstriction, especially the cutaneous vasoconstriction caused by the noradrenaline. It interferes with the evaporative cooling, which is the mainstay of treatment in case of heat stroke. So noradrenaline is to be avoided. And in this particular patient, the patient had severe tachycardia. We didn't want to subject the patient to further tachycardia and dysrhythmias by using dopamine. So we had to use dobutamine along with judicious fluid resuscitation in this case. And there's another question. What is the complication that should be anticipated and prevented when rewarming a hypothermic patient? Dr. Qamar, can you tell about this? Please unmute.
Sorry. This is a good question. Usually when we rewarm a hypothermic patient, we initially start with external rewarming. IV fluid is an internal rewarming, but it takes time to rewarm the cores. And where this ECMO is not always available. So we start by external rewarming, either blankets or heaters. So when we start external rewarming, the skin becomes warm before the core. So that causes vasodilatation at the skin. So when the cutaneous blood vessels dilate, the blood which is in the core, that rushes out. So that drops the blood pressure. So that's why in the case which I told, the BP was NR, still we were giving boluses 2.5 liters we had to give. Then the BP picked up. So that is one problem. You have to anticipate a fall in blood pressure or a non-responding hypotension. Second thing, when the patient rewarms, the core temperature further drops because it is now perfusing the areas which are cold. Still, the blood vessels have dilated, but still the body is cold. So the core temperature, the blood from the core goes to the peripheries and it gets it gets colder and the cold blood comes back to the core. So it causes drop in the core temperature, which we are trying to rewarm. That is called an after drop. Okay, after drop of core temperature. So we should be worried about that, because when there is an after drop, it increases the chances of arrhythmias again. So these are the reasons why. And second thing, these are the reasons because the patient is also dehydrated. So you need to give a lot of fluids, and you need to keep them warm. Keep continuous warming should be continued in such cases, and fall in blood pressure and after drop core temperature and dysrhythmia should be looked for. I hope I answered the question.
Yeah. Especially you wanted to tell about the after drop phenomena.
Yes.
Right. Okay. Here we can see another question. Can we discharge a drowning victim immediately if the patient is asymptomatic? Or I will answer this question. In cases of drowning, the symptomatic patients, they have apnea, unconsciousness, and they land up in hypoxia due to the lung injury. And also likewise, they are even present with the dysrhythmias also. But please always remember that even if the drowning victims, even if they are asymptomatic, they need to be retained back in the emergency room for at least 6 hours. There can always be late presentation of these symptoms, which are seen immediately. So there can always be a late presentation. These patients, the drowning victims, they should be observed for at least 6 hours before discharging from the emergency room. That's the catch point there. And the next question is, what is the effect of alcohol in hypothermia? Dr. Qamar, can you tell us?
Alcohol, actually, there are multiple reasons why alcohol increases the morbidity of a hypothermic patient. Usually we have a thermoregulatory set point in the hypothalamus, which controls the increase. If the body temperature increases, it will bring it back to normal by sweating. If it decreases, it causes shivering and it brings it back to normal. So that's a thermoregulatory center in the hypothalamus. Alcohol interferes with the thermoregulatory center. So the natural defense of warming up the body when the body becomes hypothermic is gone. Second thing, it causes cutaneous vasodilatation. So that the core temperature again decreases because the patient is losing heat because of cutaneous vasodilatation. So third, it causes diuresis. The patient becomes dehydrated also. And because of influence of alcohol, the heat-seeking behavior is gone. Usually when you feel cold, you'll wear a blanket, you'll go in a house, you'll want to feel warm. But in alcohol, because of disinhibition, the heat-seeking behavior is altered. So patients may not be able to keep themselves warm if they are under influence of alcohol. So that is the reason why alcohol causes more morbidity, especially hypothermia. I hope I answered the question.
Yeah, that was a very good explanation, going right there into the microcirculation. And we go for the next question. Despite cooling measures, poor outcomes are seen in heat stroke patients having what features? I think Dr. Sai, you can answer this question.
Yeah, definitely. That's a good question. In spite of your cooling methods also, definitely the patients with advanced age who need, who are in hypotension, who need endotracheal intubation at the time of presentation, and who are at the altered coagulation factors or coagulation values at the time of presentation will definitely have a very poor outcome in spite of your best efforts. I think
So,
that
yeah,
is,
you're done with the question.
yes.
So we are done with the questions. So I thank both of you, Dr. Qamar and Dr. Sai, for your wonderful presentations and made us realize how to think out of the box when we encounter the environmental emergencies. I thank all the viewers for your active participation in this academic activity. Thank you, one and all.
Thank you.